Good afternoon. I'm Tony Farley, Interim Chief Executive of the Australian Healthcare and Hospitals Association. Welcome to today's webinar, Nothing Special About the Problems in Specialist Care, Developing a Vision for the System. I'm joining you in Canberra from the land of the Ngunnawal and Ngambri people and pay my respects to their elders past, present and emerging. I'd also like to acknowledge and pay respects to the traditional owners of the many lands on which we meet and recognise their continuing connection to land, water and culture. 2/3 of Australians currently have to pay out of pocket for appointments with specialists, such as psychiatrists and cardiologists, often hundreds of dollars per visit. For those with complex chronic conditions that demand targeted interventions, these costs quickly add up, with nearly 1 million Australians delaying or skipping specialist care due to cost, risking their well-being and driving up pressure on hospitals. Creating meaningful change to address these difficult problems requires developing a vision for the system and challenging the process by which we manage, fund, deliver and receive care, which have been left on autopilot for too long, as the report says. AHHA is particularly keen at this point in the electoral cycle to highlight the opportunities that exist for the current government, with such a large majority and so many opportunities having been in government for the previous term. A lot of the problems that we will be talking about here today are not new to anybody. We understand that there is dissatisfaction across the system about the way in which this large and highly effective system works, and questions about its affordability and overall sustainability. So it's particularly important for us to be talking to Peter Breeden here today from the Grattan Institute about this particular report, because it coheres and relates to a much broader system, and the problems that we will be discussing today with specialist care applies across the board in a range of areas. Peter Breeden is the Health Program Director at the Grattan Institute to explore insights. He's here today to explore insights from their recent report, Special Treatment, Improving Australians' Access to Specialist Care, which has captured the breadth of challenges that are undermining the accessibility of specialist care, appropriately described as a pay or delay system. If you have any questions for our panel throughout the session, please use the Q&A function at the bottom of your screen, and we'll try to get to them throughout our discussion. But first of all, we're going to begin by asking Peter to introduce himself and present the key findings of the report, and then we'll have hopefully a very lively discussion afterwards. Over to you, Peter.
Thank you so much, Tony, for that great introduction and the opportunity to speak here today to what is a really large, expert and diverse community of your members who will have great insights and questions, I'm sure, about this work. I will kick off straight away just by running you through the findings of our report, and then there'll be plenty of time, as Tony said, for discussion. Okay, here we go. All right. So, the first big problem in the system that we talk about is the high and rapidly rising fees for people to access specialist medical care, by which we mean non-GP medical specialists. For brevity, we're calling them specialists, in the private system. You can see here that fees have shot up really fast, rising by over 70% in real terms since 2010, and much faster than many other kinds of healthcare, such as GPs and other MBS-funded services. So fees are high, they're rising quickly, and they apply for a lot of visits in the private system. This is, I think, a really interesting finding, which is that even some of the poorest Australians are paying for specialist care a lot of the time when they go to a private clinic. So as you know, bulk billing for GPs is very high, around 8 in 10 visits, but you can see here, even people on a weekly household income of less than $500, most of them, nearly 3/4 of them, are paying a specialist bill at least once a year. And the fees are also relatively high even for poorer people. So this chart shows you that 10% of the lowest income people paid over $480 in 2023, and half of them paid more than $170. And while you can see on the right-hand side of this chart, wealthier people pay more, it's not that much more when you consider, how much the incomes differ across these groups. So fees are high, they're charged a lot of the time, and even poor people are having to pay them. And as Tony said, the result is so many people missing out on care they need. Now, if you can't afford to pay for care in the private system, you're forced to wait for care in the public system too often. Now, this just shows you the top 10% of wait times, the longest wait times in Victoria and Queensland. And you can see here, even for urgent first visits, in many cases, people are waiting weeks, months, or even in some rare cases, potentially a year to get the urgent care that they need in the public system. And alongside the high fees, alongside the long waits, you see this pattern of a lot of communities not having enough care. Now, our report for the first time brought together data on the public care delivered in public hospital outpatient clinics, shown in this chart in red, I should say, and the private care delivered in Medicare fund subsidised clinics in the private sector, shown here in orange. And these are just small areas throughout Australia ranked from their total level of care, public plus private, from the lowest level per person to the highest level per person. And you can see the drop-off is quite dramatic. And what you'll also see is that red public care is not compensating for the drop-off in private care. So as a community gets less care from privately owned clinics, you don't see the public sector. It drifts up a little bit towards the left of this chart, but you don't see it compensating enough. We really need more targeted public investment to go to those communities that have the least care overall. It's no surprise to anyone here, I'm sure, that the level of services per person is lower in poorer communities. That is what this chart shows, and everyone here will also know that those people, on average, need that care more because they have higher rates of chronic disease and various health risk factors and lower life expectancy. Similarly, no surprises here that rural people are more likely to miss out, with services per person significantly lower once you leave cities, and then very low in the most remote parts of Australia. So those are the problems. We've got too many Australians faced with this terrible choice of paying what they might not be able to easily afford, waiting too long for care, resulting in 1 million people saying that they're skipping that care or putting it off. And as Tony mentioned, this is not a system problem with a single quick fix. Sorry, this is a system problem that doesn't have a single quick fix. It really does need a holistic solution that looks at the way the whole system operates. And that's what we've tried to do with our report. So we think the underlying problems that must be addressed are shortages for some kinds of specialists, those holes in the safety net where the care isn't in the communities that need it most, variation in the practices in public clinics, which mean they're not, seeing as many patients as they could, unnecessary referrals that clog up the system, and then finally extreme fees. And we have recommendations relating to all these problems, and I'll quickly go through them now. On workforce shortages, there are some types of specialists that have long been acknowledged as being in persistent undersupply. Here you see the examples of dermatology, psychiatry, obstetrics and ophthalmology. And yet, although we have too few of those kinds of specialists, they're growing slower than average, right? So this shows that the training pipeline is not giving us the specialists that we need for today, let alone for the future. And so we have a range of recommendations about the training pipeline. So the first is we need to plan. If you don't plan, you can expect the wrong supply of workers. And the National Health Workforce Planning Body, Health Workforce Australia, was of course abolished back in 2014. We and others such as the AMA are calling for that body to be re-established so we can actually start to understand the number of specialists we need. We propose that that body come up with, by specialty and by state and metro and rural, come up with the number of training places that are needed. We then say we should boost training funding by $155 million, but we should align all of that training funding that goes to public hospitals with those targets that are set by the national body. So in order to receive training funding, a state will have to be delivering through its public hospital system the right mix of trainees in the right places. We also say colleges should get extra funding to help develop more flexible training opportunities, including in rural areas. So that column of this slide is really about planning the workforce we need and then making sure the funding flows to the right places and giving colleges a bit more help to support the shift. We also think that accreditation needs to be reformed. So there's lots of evidence that the standards set are sometimes unnecessary and also highly inconsistent, which places a big burden on hospitals trying to provide training places. We think there should be some standardization of those accreditation requirements, and they should be simplified. Now, those changes are really important in the first two columns of this chart, but of course, the gestation period for a specialist is a very long time. It'll take quite a while for those changes to flow through. In the meantime, we think there are opportunities to make migration for internationally trained specialists easier, and we can also expand recognition, mutual recognition from comparable systems. We've seen that already with GPs and with some kinds of specialists. We think that can be expanded a bit further. So those are our recommendations about the issue of undersupply of certain types of specialists. Now I'll go on to the question about expanding capacity in those areas with too little care. The National Health Reform Agreement is currently being negotiated between the Commonwealth and state and territory governments. And we're saying that that agreement should enshrine a minimum level of specialist care that all communities should be guaranteed to accept. This is all about moving our health system a bit more towards a population health budgeting approach, where we really look at the supply and demand of care, and where there are holes in the system, we fill those holes. The example we've given is if you said that, okay, we're going to bring the bottom quarter of areas up to the top of the bottom three quarters, so it's not bringing them to the middle, but it's bringing them up from the very bottom, that would cost around $500 million a year, and it'd be about 1 million new public services. You'll see in the chart here on the right, that's the red top up. And the reason it's a bit jagged is because different areas need different specialties to be added in. But we also stress that, a lot of this is rural, as I'll get to. We should use existing health infrastructure to provide these services where that exists. That's the most sort of productive and certain way to get the new capacities, expanding public hospital services. We can also think about ACHOs in relevant areas. And we should, of course, utilise new models of care where that's right, particularly in rural, including, virtual care and innovative workforce models. So this is one of the most important recommendations in our report. Actually put together the public and private supply to get a real understanding of who's missing out, and then target new expanded public services in those areas. As I mentioned, this is an aggregate measure showing, the total volume of supply. If you look at all specialists combined, how much would you need to increase public services to fill the gap? If you use that approach, you can see these areas largely in rural parts of Australia. You're talking about a 10%, 20% uplift in public capacity. But we've argued that a more detailed model should be developed that does that risk adjustment we did for the aggregate measure for all the different types of specialty. And you can see here, if you do look at individual specialties, a more diverse range of areas pop up across Australia where there's really meaningful shortages in these examples here: psychiatry, cardiology, and paediatrics that need a significant boost. I'll now go on to something that I think will be of interest to many people on the call, which is the question of modernising and improving the productivity and throughput of public hospital outpatient clinics. We did a lot of consultation and research for this report, obviously, and one thing we heard and saw was that specialist clinics are really diverse in how they operate compared to other parts of hospitals where you see a little more of a kind of core default standard approach. So big variation in workforce roles, in triage, in the use of technology, in admission thresholds. And we saw that in the literature too. The literature isn't hugely extensive, but it does show there's lots of opportunities to spread best practices that already exist, which I'll talk about a bit more. And some of that variation I'm talking about, it comes out through the data. This is public sector, public hospital outpatient clinics. We've excluded rural areas here, just because this is a measure of review appointments. So in the individual dots representing a hospital, what proportion of patients have been seen before versus for the first time. We excluded rural here because gaps in primary care in rural areas might mean there's no alternative but to go back to the specialist clinic. But here you can see, really huge variation. And we'd like to see, better partnership with primary care, as we'll talk about later in this presentation, GPs being supported to do more, But this is just one indication of how some specialist clinics are much more likely to hold on to patients than others. While the data are imperfect, it does show you quite a stark level of variation. And this one's the same, but this time it's looking at the level of virtual care provided. And again, the share of interactions that are virtual varies really hugely across individual hospitals within cities. So what do we need to do to make sure that our proposed $500 million investment in public hospitals really gets the most bang for buck? We've said that, for a start, the National Health Reform Agreement should set out public clinics' role and really say why they're so important, what they're there to do, and a performance measurement framework that is consistent and transparent. A lot of states and territories don't report waiting times, for example. Some do. We think that should be done consistently. And then we think states and territories must have clear agendas to support these clinics to improve productivity. Some jurisdictions have made a start down that road. And then we also propose some funding changes. So we think the Independent Hospital Pricing Authority should look at pricing and make sure it's targeting an efficient best practice price. We propose replacing MBS funding, which funds some public clinics, with activity-based funding in metropolitan areas. There is a fair bit of evidence that MBS funding not only can it skew decision-making, there's been a lot of issues of double counting and funds having to be repaid. It adds an administrative burden for clinics and some rigidity about having to have a named specialist be accountable for each part of care, which can potentially inhibit different workforce models. There's also been cases of fraud with the MBS funding in these clinics. So for a range of reasons, we propose shifting across to activity-based funding, starting in metropolitan areas, because in rural areas we've heard that it might threaten some continuity and retention of staff. So to be safe, starting in cities. And we also say there should be meaningful funding through the National Health Reform Agreement to scale, a set of best practices within clear themes across the system. Because of course, it's hard to come up with money to change practices, and change needs to be properly supported. We didn't dictate all the ways that specialist clinics can improve, but based on the literature and people we've spoken to, we think these are good themes to focus on. Uptake of virtual care, top of scope roles to make sure everyone's doing everything they can in the team, and then integration with primary care. We'd really love to see supporting primary care become an even stronger core focus of public clinics to integrate the system and make it more productive as well. The second last area of recommendations for us was a secondary consultation system. So this is where GPs consult non-GP specialists for advice about patients. We've looked at systems in Australia, in Queensland, and in Canada and the US. And in these systems, the GPs ask a question about a patient of another kind of specialist, and they do it through a text-based system, and they get a response within 3 days. Now, where these kind of systems have been introduced, as you can see in this chart, you'll see 3/4 or more of the patients about whom the GP asks a question do not then get referred on to another specialist. So that is quite a bit of specialist referrals that are avoided, which just takes pressure off the whole system. And it's a much more efficient way to get this advice for GPs than trying to ring around, find a specialist who will talk to them, synchronize the diaries, and neither of them, of course, are directly paid for that. So we propose that the model in Queensland be scaled up nationally. In the last state election, the West Australian government committed to something similar, but we think all states should do this. We estimate the costs would be quite low, below $30 million nationally, and it would avoid more than 60,000 referrals, which is a great way to free up capacity in the system. Last one, and the one that generated most of the media coverage, even though it would only affect a very small proportion of specialists. We think that, look, if you solve all of those problems, so if you invest in public capacity, that does give people more options, which is great. If you make those clinics more productive, that gives people even more alternatives to get free care. And if you increase the supply of workforce, that should help, potentially bring down fees. All these things are good, but even if you solve them all, you've still got some problems that you're going to still have these really high fees because, people probably don't have a lot of choice. It's really hard for them to assess the quality of their care. Because it's not really a functioning market, because supply is constrained, because consumers can't evaluate the care, and for a wide range of other reasons, we think you need to take action on the extreme fees. Fees have been rising so fast, and some of them are clearly unreasonable. And again, we're not the only ones saying that. Doctors groups have also said some specialists are charging too much. And important to note, there's no evidence there's really high fees mean better care. We looked at the data, and it doesn't mean that doctors are subsidising their poorer patients more. In fact, those doctors charging extreme fees also charge poor patients more than the average doctor. So there's no good reason for these fees, in short. There's, of course, there can be variation in fees. You might be a more experienced doctor. You might treat tougher cases. You might have higher rent. But we defined as extreme fees only those ones that the patient is being paid 3 times the scheduled fee. Now, that's really so unanchored from sort of any reasonable expectation that we think it's safe to call those extreme fees. It only affects less than 4% of doctors that are charging these fees. Because there's so much uncertainty about whether the scheduled fees are at the right level, that's why we've been so conservative and just gone for extreme outliers. But for those outliers, we think that at the end of the year, the government should say, look, if you are charging those levels of fees, we should claw back funding from you equivalent to the rebate that government has put in, because we don't think taxpayers should be subsidising really unreasonable fees that harm patients for no benefit. There's a few more other recommendations in our report. We talk in there about making sure that patients are aware that they can use their referrals for all GPs. We talk about the Cost Finder website, which the government has announced they're going to update with data about specialist fees, so that people get a better sense going in what they might be charged. So I haven't comprehensively gone through everything, but I think I touched on really the big ones and given you a picture of how we think everything in the system really does need a rejig. This has been left on autopilot for too long, as Tony said, and those interventions have to span right from training through to the fees charged in the private sector. But look, I'm sure you have many questions. I look forward to, as Tony said, a lively discussion, and I'll stop sharing now so that I can hear your questions and views. Thank you.
Thanks, Peter, for a great overview from a very important report. Let's just start with this. I just wanted to ask you the question because it's you put this out there. When you put a report like this out, what's the process of consultation and feedback that you get? The good, the bad, and the ugly. How does that happen for you?
You mean after we release?
Yes.
Yes. Well, we get a lot of feedback. We get a lot of commentary. I've been, and sometimes we get people who are very upset and offended, of course, but we try to be really evidence-based and really even-handed in everything we produce. I think I've had a lot of positive feedback on this one. I think the problem obviously resonates with everyone delivering care in the system and everyone receiving care. I think people know that these are real problems. And we have had a lot of people say that, these solutions are right ones. Importantly, Minister Butler has said, look, this is an issue that's really harming patients and they want to take action on solving these problems this term, which we were really pleased to see. In terms of the pushback and the critiques, we might hear some today. The ones I'm aware of, people have said that, declines in or slow indexation for Medicare might be part of fees increasing. The data show that can't explain most of the fee increases, so I don't think that's the main issue. But we do propose to review the Medicare benefit schedule fees to make sure they're adequate. So we have covered off that, which some people may not have picked up on a quick read. Others have said we should have been meaner and criticised more parts of the system more fulsomely. But I think what we found looking at it is that the whole policy settings aren't in place to get the right outcome. So if you don't have a plan for what you need, if you don't fund the key players to do it, how can you expect better results? So, rather than criticising individual entities more fiercely, we really focused on the system settings that are kind of letting everyone down and tried to focus on how they can improve.
Now, it's a national system, and there are all sorts of locus of control is all over the place. I mean, if you pick up on something like this, it might be an obvious question, but it doesn't seem to me to be answered in terms of practical implementation. Who is responsible for driving the sorts of reforms that you're talking about here? Who specifically?
Yeah. So specialists is a tricky one because it's even more of a federal state sort of muddled responsibility than some other parts of the health system, and many of them have that characteristic. So I do think it needs a national plan. And that's why we focused on the National Health Reform Agreement that's currently being negotiated as a key sort of target for our advocacy. So in that, for example, governments could come together and say, this is the minimum level of care we expect for a community to be able to get, and we're going to fund, the public system accordingly to fill those gaps. That would be a national agreement where all ministers would need to be accountable and responsible for achieving the outcome. But we do have this national agreement. The Butler ministry did initiate a review of that agreement, and that review, that independent review in the last term, said it's not a reform agreement, it's just a hospital financing agreement. So that critique is on the record, it's been sought by the minister, and so we hope for a much more reform-oriented agreement. I think that is the forum that can really bring this together. There are other actions that can be taken by state ministers. I think driving that productivity agenda, publicly reporting the data, the national agreement can support that, but there's also independent actions that state ministers can take. So look, unfortunately, responsibility is a bit diffuse for a system problem that has elements of public and the private together. But yeah, that's why we call for a big national agenda.
Okay, let's put you to work and give you some difficult questions here. Let's start with one of the questions, which is, Peter, an increase in training places is one thing, but what about colleges artificially keeping specialist numbers low? Is that an issue?
So for most types of specialties in undersupply, there are more applicants than there are, getting approved to go through. We think that sort of excessively onerous and inconsistent accreditation requirements are one of the problems there. So we've proposed that they get simplified and standardised. That would help more people get through. But it's hard to hold the colleges to account for a target that doesn't exist, right? So we propose that we should actually set a target, give the colleges a bit more resources to help achieve that target, make sure the money flowing to the public side is tied to those targets, and then you're starting to align all the incentives in the system. You're resourcing it, you're setting the target, you're making sure the resourcing is there on the public side, you're giving the colleges some money to throw in to fix the problem. And then what we've said, look, if you don't then unblock training, if you don't then get the places you need, then there's an escalation path where ministers can step in and take more control from colleges. But we think the first step is to get targets in place, make sure everyone's incentives and resources are there. And we think that will unblock the pipeline. But if not, further action would need to be taken. But I think we've got to give a chance for colleges to get the incentives and resources to be part of the solution.
I understand human nature and blame and finger pointing, that sort of thing. Why is it so difficult in healthcare to get a consensus on a lot of issues like these?
Look, I think that in any change, there's going to be people whose personal interests are threatened. We are really only looking at outliers here when we talk about fees that are too high. It's just a small minority of specialists. But I can understand that can trigger people's apprehension about, their income and their livelihood and so on. So, that's understandable. I think healthcare, even Minister Butler said that, look, there's a lot of loud voices and pointy elbows in this space. I think, it's a really hard question. Part of it might be that, look, to my mind, it's been a while since we've had a structural, obviously successful health reform that's really moved things forward for clinicians and patients alike. Now, that might seem too harsh, but I think there's a lot of skepticism in the clinical community and more broadly about reform itself. People, aren't sure what can happen. There's a level of cynicism that can creep in over time. I think there's a big opportunity now to get change for a lot of reasons. You said at the top how everyone's aware of these pressures in the system and how hard it is and how things aren't sustainable. I think the government is up for reform. So I think we need to, whatever it is, and I can't diagnose the exact underlying reason, but it is time to snap out of defensiveness, I think, and cynicism, and really everyone can contribute to a positive agenda for change, given the need is so great and so pressing, and given that many reforms are long overdue. So, look, I can't say exactly why it's so hard. I think there are a lot of the groups within healthcare make such an important contribution and have such high status, and they have rightly strong voices, loud voices they're listened to a lot. And so that can mean, getting consensus can be harder when you have a lot of really powerful, really well-resourced, really important groups. That can be part of it. But I am struck that other countries do this. We see really big health reform more than in Australia. So I guess we all have to look inward as well and go, look, in our role in the system, what can we do to break the deadlock?
Is it a case of political will meets bureaucratic capacity?
Look, I think that it's rare for all of the elements of the window to open up at one time. The solution to be clear, the political appetite to be there, the bureaucratic capacity to be there, the sector to be a willing partner. You sort of need all of those stars to align to get real change. And so maybe it's not surprising that doesn't come up every day of every year. But look, I think, I think many of those ingredients are there. And look, I mean, my job is to try and put the best evidence-based, most persuasive proposals out there and try and persuade everyone and convince them of our view of what's the right way forward. I hope this report's a contribution to that. And I mean, like I say, I'm hopeful. I think to your question, I think political will is sufficient, and I think bureaucratic capacity is sufficient too. So I don't think they're the biggest blockers.
That's good. Okay, let's get into some more of these questions. Shelley Burgess asks, do you have additional differing recommendations for streamlining registration processes for overseas trained specialists than what has been made via the CRUC review?
Shelley, it's very aligned. It's pretty similar to what the CRUC review is talking about. So we thought they were sensible proposals. We understand they're getting a really good hearing inside government and health departments. So we're really supporting the directions that she's outlined.
Okay, let's pick up on something that James Hodges is asking about. Just interested about the recommendation to replace MBS funding, as this can be a lever to persuade public health executives to invest in specialty outpatients. I would like the rules for public hospital specialist MBS billing to align with private providers, which is far more flexible. What do you say to that?
Well, I'm not sure if I'm getting to the question correctly, but our proposal is to replace it with activity-based funding. So, of course, many clinics already use the activity-based funding. I mean, one point I should raise that I didn't in discussing that is that one reason that state health departments and hospital clinics kind of like to sometimes use the MBS is because it's not constrained by the cap in growth for hospital funding under the National Health Reform Agreement. So we've made it clear that when you switch across to activity-based funding, that new activity should be above the cap. It shouldn't be counted towards the cap. So there should be no loss of revenue from switching across. And then regarding, we basically think it's not fundamentally, the MBS is, not an amazing funding model, right? It's not really that well linked to cost. And it's also not really geared to public hospital clinics, which operate quite differently to private clinics in terms of the staffing mix, the acuity, like the whole shebang. So it's kind of not fit for purpose. It's got all of these administrative constraints and problems. And the question is, right, you could streamline some of those maybe and keep the MBS, that may be possible, but you still be left with those other problems. That's why we propose shifting away from it.
You talk about investing in public clinics where they're needed most. We'll get to the issue of the rural and remote and the issues related to that in a moment. But just in terms of the relationship between obviously the GPs and the specialists, does there need to be a more established, more structured approach to that? Is it high functioning at the moment? And we're talking about clinics that sit there within the public system, but where are the GPs in all of this, the private practicing GPs?
Yeah, look, it's a great question. I mean, I think, this idea of making, specialist clinics do a lot of work with GPs, right? And there's a lot of coordination, communication, and so on. But I think that recognizing this as a really central function of the specialist clinics is important to help to position them to be supporting primary care, supporting GPs to do more as a really core function. And make that more consistent across the board. I think that's important to, I guess, elevate the role of GPs, allow them, support them to do more. And the relationships can be really strong, but they can be weak between GP clinics and their local specialist clinic. I think, the GPs, the central point for a patient in terms of managing all their care, of course, they should be, well supported by all the system. And anecdotally, we hear that it can be quite hard for GPs to engage with specialist clinics. That's why we propose this really low friction, efficient model. And I guess one thing I should say, it doesn't replace the need for other kinds of coordination and secondary consultation. Our focus of our report was really how do we maximise that access to specialist care? This form of secondary consultation is the most effective and efficient way to do that. But I think your question is getting to there are other things that need to be done. Secondary consultation that is more about, GP skill development and specialisation and training, and you can have joint consultations, and you can have You can have sessions out in primary care to better integrate the system. So that was a bit out of scope for what we were talking about. But I mean, the shorter and less rambly answer to your question is this interface is, of course, really critical. And everything I hear is that it's not always working very well. Our report touched on that, but it didn't sort of talk about strengthening that as, you know, a really deep look at all the ways, just the ways relevant to improving access to non-GP specialist care.
Okay, let's pick up on a question from Steve Flecknoe-Brown. He asks, in rural and regional paediatrics, increasing patient complexity is mirrored by increasing financial hardship. This has made private practice virtually non-viable. Right. The result has been that rural hospitals have become more reliant on the staff specialist. This increases the clinic work wait times, as well as putting severe strain on the after-hours roster previously covered by VMOs with private practice. The solution here, that's a question, please don't drive these people into the arms of the corporate. So what's your response to Steve's point there?
Well, you know, Steve, that sounds really tough. So I'm sorry that's happening. Sounds very stressful. And I can imagine there's sort of this moral injury dimension of really being struggling to meet the needs of this community. So, yeah, look, I think the big one for me is investing in that public capacity in those communities, right, where there's not enough care. I mean, this is what Steve seems to be talking about, is that, you know, they've got greater needs for healthcare, probably because of, I'm guessing, the disadvantage and the challenges that he seems to be referring to, but then the inability to access the private system. So I think we need a health system that looks much more at where those gaps are, which I think we can estimate using the data that governments hold and that we've had a go at, and then investing in those underserved communities. Because our data, is probably worth saying, our analysis is based on the patient. So all of this stuff about is, did the individual in this community get care compared to over here in this other community? And, you know, those gaps can be tracked. Other countries do that and then invest, you know, where the services aren't. And I think that would alleviate a lot of the pressures that Steve's talking about.
Okay. One of the things that in any endeavour, but particularly I think in healthcare, that drives behaviour is not wanting to lose whatever autonomy or control one might have, and it's across allied health, nursing, midwifery, and doctors and everyone, and executives, I have to say.
Yeah.
You make a recommendation in terms of modernising the public clinics, which is about states should give public hospital clinics clear guidance on best practices to maximise productivity. Now, if I'm a clinician and I look at that recommendation without diving deep in it, I might be a little bit concerned that, well, what, you're going to tell me how to do my job day in and day out. What does that mean in practical terms, in terms of the report?
Yeah, it's a good question. And look, this is part of why we didn't go and say this is exactly what clinics should look like and how they should work. But I think that the people we've spoken to in specialist clinics, most of them were pretty clear that they do see huge variation in practices, even within the same capital city, and that there is a role for more systematically spreading the best practices. Now, you're right. We don't want to move towards a really rigid standardization where people can't respond to the needs of local communities in different ways. Or the budgets and et cetera that might be different in the institutions. But I think there is a role for some sort of at least establishing some evidence-based defaults, right? And saying, well, this is what we think is a good model. We're happy to support you to adopt it. And we talked about the importance of change support. And I think a lot of people are a bit over a proliferation of time-limited pilots for a range of sort of scattered different initiatives for improvement. We sort of outline a different model where we say, let's work out some clear themes for improvement. We talked about what three of those might be. Let's get some relatively consistent models that we think are right that then might need to be tailored on the ground. But then let's have a sustained stream of funding to set them up at scale across the system. That's what we'd love to see state departments doing. I won't say it's easy. A lot of the people we've talked to who are doing great work in specialist clinic improvement, are already doing good things. And also it is really hard. It is hard to engage all the workforce groups. It's hard to make change happen. But I think that, rigid standardization, may take away too much autonomy. And I understand it can be a sense of threat to people's autonomy. But at least from the people we've spoken to on the ground, we feel like having a clear direction is actually liberating. Where is this system going? And then if you have a set of default settings that you can adopt with tailoring and you're supported to change it, I think most people would agree that's a status quo improvement. But I think the anxiety you've said is 100% real and understandable, and of course, very human.
So is that a matter for the next agreement, the next national agreement, and to be far more specific in terms of both what the outcomes are being sought, and then who's responsible for delivering, and then the third thing is tying money to it. Is that, how do we make this happen? Because I mean, everywhere I go, people just say this. We've been talking about this for 40 years.
Right. Yeah.
That's a long
That's a tough
time.
one. Yeah, well, you mentioned that every clinical group understandably wants autonomy, so does states as well. So we think that the national agreement should have a role here for sure. That role should be, look, let's at least specify, what are the really important functions of specialist clinics? They are here to provide care to people who can't afford, the private system. And then let's enshrine in that agreement for this 5 years the broad directions for change. That national agreement shouldn't have operational detail in it, but it could say that, look, we're really focused on virtual, top of scope work, integration with primary care, whatever those top level themes are. And then it should also have the money for change. And say, okay, so within these broad directions, here's the dedicated funding over the 5 years to get change in the system. Now, then the states have to do the more detailed work that might be slightly different from state to state, which is say, okay, how do we realise those directions in our jurisdiction? But they should provide, again, a really clear model so that we can start to, again, with some local tailoring where needed, get a little bit more consistency and drive change at scale. Because if it's too fragmented, if it's too inconsistent, it will never actually change the system. It will end up, with these little pockets of great innovation, which we have heaps of in our system, but without actually shifting the system as a whole.
Yeah. Okay, let's go to the unnecessary specialist referrals. I mean, that's the sort of heading of it. But Karen Hutchinson asks this question: how can we drive and speed up the scaling up of the e-consult partnerships model you mentioned in Queensland between GPs and specialists to support those living in rural and remote areas who struggle to access specialist care?
Yep. Well, we propose, doing that. So I think that, we talk about probably, again, states will have to work out the best way, but we say that the default provider should be a public hospital or a set of public hospitals. And there's no reason that this asynchronous text-based communication can't occur with rural clinicians. And I would argue that's the most important place to have this system support rural GPs for a couple of reasons. One, those GPs have less specialists, other non-GP specialists in their local ecosystem to lean on and get advice from. But also it's where you have more internationally trained GPs as well, who won't have those personal networks from medical school, sort of the friends they can ring up and contact. So hugely important that this model apply to rural areas. And to your point about how to do it, I mean, we've proposed and assumed in our investment proposal that this would happen, that rural areas would be eligible. We've talked in the report about the kind of performance measures you would have for such a platform. That includes like GP satisfaction, the proportion of referrals that happen subsequently to the consultation. But we haven't said this in the report, but I think the equity of the uptake and the uptake in rural areas could well be, and I would support it being, another performance measure for such a system. So just supporting your view, I think that it's really important that rural clinicians get access.
One of the issues with workforce in terms of rural areas, remote, I think is a sort of another level again. But in terms of rural areas, a critical number of specialists within a particular area or hospital. And you can see, this size issue, and there's this problem of getting specialists to come. It's the fly in, fly out model in a lot of situations. How do you deal with that when the rural areas have changed in terms of the social makeup, the socioeconomic nature of those communities? What they were 50 or 60 years ago are completely different to today. And people are wanting more and more to live and hug on, to the coast. How do you deal with those issues? And is technology going to be a friend, or we just have to accept that there's a locum sort of model in specialist care that's inevitable? What's your view on all of that?
Well, in our costings, acknowledging these challenges, there's already a loading that happens for remote within the funding model, and we put an extra loading on top of that when we did our costings, acknowledging, it's going to cost more in rural areas, and as you said, particularly remote areas. There's lots of work going on around Australia in using virtual care and sort of hub and spoke models to try and extend access to specialist care out to those areas. I think that's absolutely part of the solution. But it's, I think what would be highly motivating, in my view, is if we had a national funding agreement that said this new money is dedicated to those areas that have an undersupply of services. And it's use it or lose it. It has to go to these places, right? And then I think we have enough, great ideas and pilots and models in the system to find solutions for those challenging things. And sometimes it will be clinician transport, fly in, fly out, patient transport. Sometimes it'll be virtual. Sometimes it'll be better leveraging existing infrastructure that might be there, like ACHOs or other things. So look, I think there's got to be innovation. The reason we have that loading on there, we don't think it's in many places a status quo delivery model you can just transplant out of cities, that's for sure. But I think a forcing function here is to have that dedicated funding that must go to these communities, and then making it sufficient to implement new models. And I hope that would unlock all the innovation needed to get care in those areas.
I just wanted to go to the equity issue for a moment. And it's to some extent, I think, with these equity issues and the obvious disparity that exists between access and for those areas that are relatively wealthy, and then you move to areas where they're not. This is a really difficult question, I think. How do we give voice to people who are the most disadvantaged? And how do systems engage with that, seeing the disparity that sits there in terms of access and cost? How do we give voice to people in a contemporary situation so that we can see what they're reporting, what they're experiencing, and understand those outcomes from their perspective? Do you have any views on that?
Look, I think that it's really important for all decision makers in the system, from ministers and departments to the leaders of healthcare delivery organisations and frontline clinicians. I mean, we should all be attentive to all the voices in the community, particularly those ones that aren't getting care, through their, the relevant representative bodies. We hope that consumer organisations have that diversity, within the stories that they're drawing from and amplifying. But in a way, and this is not the whole problem, there's lots that you're getting at about stigma and discrimination and, how we blind ourselves to different people's experience. And those are deep social and cultural problems. But there is one really simple part of this, which is looking at the data. We know, and this is what we've tried to do, we know who's not getting care. We know the cohorts. And now with linked data, as in many other reports we've shown, we can drill in and understand which migrant communities are not getting vaccinated, which rural communities aren't getting GP services, even if they're, people who are over 65. We can measure this, right? So I think that these relatively new capabilities of data, at least at that level of analysis I'm talking about, that have come around really in the last 5 or 10 years, it's time to leverage that to create accountability. And I think that accountability comes through the measurement and looking at it, but it comes through setting these targets, and we talked about in a range of healthcare domains. I think that is, again, a forcing function to make sure these well understood, long, standing disparities start to be addressed. I mean, we have to measure the problem, set targets, allocate money, see if it worked. Like, that is pretty basic. But we've got to build that into all of our policy decision making and system management.
So on data, what does the e-consult experience in Queensland, what does the data tell us there that would, as you suggest, expand that across the country?
Well, I think the evaluations are really promising. You might have seen on that chart in the way through, like, a really high proportion of the consultations did not result in a referral, suggesting, the GPs had the confidence to manage those issues themselves with that bit of extra advice. So, look, it seems like a clear success on all the metrics you might have. And there's lots of good things about having it delivered by hospital clinicians in terms of, the breadth of expertise you can get. One of the things we found in our consultation with GPs and looking at the literature is you really need to give people a one-stop shop with a broad range of specialists they can draw from to make it worthwhile, repeatedly using this portal. The model in Queensland does that. The satisfaction is high. The level of onwards referrals, which are sometimes legitimately needed, but they're low, suggesting it's working. So look, I think it's very encouraging. The evidence for this seems quite strong, also from the overseas models. So yeah, I don't see any reason to not to continue rolling that out.
Just a few more. We're getting down to the back straight on this. We have a question. What is the appetite for health workforce planning to be undertaken at a more local level? For example, postcode for rural areas. Local people understand what is and isn't available across the private, state, federal sectors, but planners based in the city do not understand this. Yeah. Perhaps PHAs could support this process. Rural people are more likely to come up with innovative solutions than city folks haven't thought of. What's your response to that, Peter?
Yeah, I think it's a really good point. And I'd sort of break this down into two things. So I strongly support looking at the adequacy of service delivery at that really small, local level. Because one of the problems we've had is we have all of these loadings in the system for just level of remoteness, right? But within those bands of remoteness, some communities are well served, some are poorly served. So I think getting back to that thing of focusing on the need, we need to use data to really, in a granular way, find the gaps in the system, not just look at inner regional, outer regional, remote, rural, etc. So I agree with that part. I think the workforce supply, like the questioner is absolutely right. Like the model on the ground might be different, and you might have an Aboriginal health nurse in an area that does something that another person wouldn't have thought of elsewhere. Or you might have physician assistants in some rural areas, which I know is a fringe model, but that does exist in some places. And a central planner won't think of all the right solutions. But I think we do need to get the supply of specialists at a sort of mid-level, which is to say we need enough rural training, because we know that's a really good thing for rural retention, and we need enough in each state. So I think those kind of big picture levels of at the level of state and metro versus rural, what are the volumes of training? I do think that needs a big national plan, but it doesn't mean that everyone has to do things exactly the same. It just means that we're getting people being trained in the right places and we're getting the right supply. Nothing we've suggested is super rigid about who should do what. It's just like getting the aggregate supply up and getting the rural supply up. I hope that makes sense.
Okay, I'm very conscious, Peter, that it's a medical focus in this, and so the last two questions are really about different other areas that are absolutely interdependent to an effective system, which your report emphasises as well. Jean asks, we still don't understand who is and isn't getting access to allied healthcare provided through private practitioners. How can we get data on this?
Well, I think you can get data on that through the MBS. If these are MBS billed allied health services, they will be in there. And for that side of our analysis, we used an ABS data asset. It's probably too nerdy to go into, but it's very rich because it's linked to the census. So you can understand income, you can understand obviously age and ethnicity and so on, linked to the MBS. So that is a really rich source of data where it's possible to do similar analysis for allied health for the clinics. The challenge for us was adding the public in, which is a different data set. But yeah, it's measurable in my mind if that's what you're talking about.
Yeah. Okay. The last one that I just wanted to explore a little bit was around long-standing issues, nurse practitioners and midwifery. And in those areas, the extraordinary load that's taken, let's just take midwifery as an example, what's done at the moment in the system, largely sort of unseen, I suppose, except for those mothers who are going in and the experience that they have, which is extraordinary. What roles or different expanded modified roles, those areas, I think allied health is the same, but let's just concentrate on, say, nursing and midwifery. What roles can they play, and how might nursing and midwifery evolve in a system of the kind that we're talking about? Have you looked at that and considered that, given the interdependence of the system and the outcomes-based approach to these models of care, what role do they play in this?
Well, obviously care is multidisciplinary, even in many private clinics, but especially in public specialist clinics. And we talked about that. And we looked at some of the literature that is promising about, the benefits that can be gained from top-of-scope roles, for nurses. We didn't do, a deep literature review of that, but certainly, previous Grattan research has looked at those kind of top-of-scope roles and how they can be used in acute settings, for example, and also in primary care. So, look, I think that is, it's a positive reform direction. It just wasn't in scope for us to do a deep dive on it in this report.
Okay, this is the last. Or there's two ones. There's a wind up one, but here's one. Got to do it because it's 2025. Bhavesh Patel asks, can we fund AI-based communication to improve on the growing expectations of our consumers who now have much more access to information? What's your view on that?
Look, I think some of this, we weren't really prescriptive about the things that the productivity improving things that should be tried. But I definitely wouldn't rule out AI as one of these things that can be used potentially. For example, in public specialist clinics to make things more productive. And I guess as a general statement, I'd say, we do want to do research in public settings about how these tools can be used, because I don't think we want that only to come from private sector settings or from overseas. So I think, for example, research hospitals, there's no reason that as part of this agenda for improving the productivity of public clinics shouldn't be looking at testing and evaluating these kind of models. I mean, it's obviously coming in lots of ways in terms of decision support and so on. The communications with patients that you mentioned is, it feels like it, depending on the degree of clinical oversight and approval you're talking about there, it feels like one of the higher risk applications to me. But look, there's no way to talk about productivity without at least, asserting we have to be really open to looking at how these exciting new technologies can be part of that.
So let's finish this up. This has been fantastic, Peter, and really appreciate it. And thank you to all who have actually been providing questions as we move through this and participating in this webinar. If there's one or two things, the sort of low-hanging fruit, what would they be?
Tony, I fiercely resist that question because we want an agenda that, government, we don't want to give the illusion that you can just do one or two things. But I don't want to be a rude guest, so I'll say, look, if you force me to only do one or two things, look, I think that targeted, focused investment of capacity where it's needed most, that to me, if we're talking about access to this really important care, I think that'd be the one I'd love to see happen, because those gaps really can't be defended, and they're definitely harming people.
Peter, I apologise for that trite question, and thank you for that very gracious response. I really appreciate it.
No worries.
Okay, that brings us to the end of the webinar. Nothing special about the problems in specialist care, delivering a vision for the system. Thank you to Peter for joining us here today alongside all of you watching online. The AHHA's Australian Centre for Value-Based Healthcare hosts a regular webinar series where we dive into topics across the health sector. If you enjoyed this one, I encourage you to visit our website to find out more about upcoming events and webinars and where our webinar recordings are hosted. Thank you so much for joining us, and we look forward to seeing you again at one of our upcoming events or webinars soon. Thank you and goodbye.